hematology, oncology, pathology, myeloproliferative neoplasms. All right, so for myeloproliferative neoplasms, all these are just malignant hematopoietic stem cells that become neoplasms, okay? So they have different types of like white blood cell and myeloid cell lineages. And the first thing that we're going to be talking about is Polycythemia vera. So this is just a proliferation, constant proliferation of red blood cells, okay? So just keep that in mind, right? I know that's a part of the myeloid lineage. So now let's look what part of the myeloid lineage. We're looking at erythrocytes. Erythrocytes are now growing rampantly, okay? But there's different types of polycythemias, okay? Polycythemia vera is known as primary polycythemia, okay? And all that means is that there's an increase in red blood cells, okay? And usually it's due to an acquired JAK2 mutation. They love to ask about the mutation, so make sure you know that it's a JAK2 mutation that's present, okay? Now, they like to ask about the presentation of aquagenic pruritus. So whenever a patient is in like the shower after showering or things like that, they get severe itching on presentation. And that's a key sign of polycythemia vera, okay? Now, they also have severe burning pain and discoloration due to just random blood clots in the vessels in the extremities due to the fact that there's so many red blood cells that it makes the blood more viscous and thicker. So it causes blockage and can cause like burning pain. Okay. And so that's why we have that association with hyperviscosity and thrombosis, because there's just so many red blood cells. Now, in response to the increase in red blood cells due to the JAK2 mutation, we're going to see a drop in EPO. Okay. Now, that is a very key distinguishing factor for primary polycythemia. Okay. Because we're going to use the EPO levels to help us differentiate it between secondary polycythemia, which has an increase in EPO. Okay. So primary polycythemia, once again, is a problem with JAK2 mutation. So at the myeloid lineage, we're just creating too many red blood cells. And so in response, EPO is like, whoa, since there's so many red blood cells already, I'm going to drop in response. Secondary, there's a problem with secondary polycythemia vera. There's a problem with our EPO. So we have a massive amount of EPO and our bone marrow just responds accordingly by producing more red blood cells. Okay, so that EPO is very important in understanding primary versus secondary polycythemia vera. Okay, understand that JAK2 mutation. Next is essential thrombocythemia. All this is just massive proliferation of megakaryocytes and platelets, okay? And we know that megakaryocytes are in the bone marrow and they produce those platelets. So if we have a massive proliferation of them, then we're going to have an increase in platelet number, okay? So we're going to have increase in bleeding and thrombosis. And what we're going to see on the blood smear is an increase in number of platelets, right? Because if we have more megakaryocytes, that means we're going to have more platelets in our peripheral blood smear, okay? They may be abnormal, but that's really essentially low yield. Lastly is myelofibrosis. Myelofibrosis is just, you're going to see atypical megakaryocyte have hyperplasia. That's a question that they like to ask. Okay, so the megakaryocytes that produce platelets, there's going to be an atypical hyperplasia of them due to the fact that there's an increase in TGF-beta secretion. Then, because of the TGF-beta secretion, we have fibrosis that fills up the bone marrow. And since fibrosis starts to fill up the bone marrow, we start to have all the cells starting to get squeezed out of the bone marrow early, before they're able to fully mature. And then that's when we get the signs of dacrocytes, also known as teardrop cells. Okay, and the reason they're teardrop cells is because they have to squeeze out of the bone marrow due to the fibrosis. All right? So just really quickly, I'm going to run through these lab values that we're going to see. For polycythemia vera, we're going to have increased red blood cells, white blood cells, platelets, okay, with a JAK2 mutation. Essential thrombocythemia is just going to have an increase in platelets. Everything else is normal, but they have a JAK2 mutation as well. Myelofibrosis has a decrease in red blood cells and a JAK2 mutation, okay? Now, before we move forward, I just want to discuss the different types of polycythemia. So we already talked about primary polycythemia vera compared to secondary polycythemia vera. Now, there can be different types of polycythemia that might not be primary or secondary, okay? And so all we mean by when we say polycythemia is that we have multiple and increase in red blood cells, more than normal, okay? So there can be relative polycythemia, which just means that there's no change in the production of red blood cells, but we've lost volume of our plasma, okay? So for example, if a patient is severely dehydrated or if a patient is bleeding out, they're losing plasma volume, but they're maintaining their red blood cell count. So it might look like we have an increase in red blood cells, but in reality, it's just a loss of plasma volume, which shows a relative polycythemia, okay? That's pretty much the most important one that you need to understand. Lastly, although it doesn't fit within this recording, I'm just going to add Langerhans cell histiocytosis. It's relatively lower yield, but if you get one question on it, it's easy. What you need to know, and this is just straightforward, this is the presentation, it's going to be a patient, okay, mainly a child patient with a bone mass in the skull okay? And once you take a biopsy of that bone mass, you're going to show Langerhans cells, which are those tennis racket-looking cells, and eosinophils. And then those cells are going to express S100 and CD1A, okay? So if you ever see a child patient with a bone mass in the skull and you're confused, just think about Langerhans cell histiocytosis. Think about how it's going to be eosinophils, and the cells are going to express S100.